In this video, I will summarize a clinical presentation of hip impingement. Expect to learn the following: clinical signs to look for in hip impingement presentation, why a hip impingement presentation usually isn't a hip flexor problem, and 4 common causes of hip impingement and how each presents clinically. For those of you who don't know me, my name is Dr. Matt Maggio. I am a soft tissue injury treatment expert. My focus is on diagnosing and treating adhesion, also known as scar tissue, and reducing inflammation from chronic injuries without the use of drugs, injections, or surgeries, which leads to a significant increase in overall functioning, flexibility, and long-lasting pain relief. I'm also the creator of the soft tissue treatment revolution and the program coordinator for Adhesion Release Methods, where we teach overworked manual therapists a new treatment system that will allow them to double their income without working any additional hours so they can stay healthy, avoid that dreaded burnout, and help more people get out of pain. All right, so understanding hip impingement, why it isn't a hip flexor problem, and 4 causes of it. So let's get right into it. So first off, we always just want to start with clinical signs, clinical presentations. This is actually called taking a history. A lot of us as manual therapists, we just want to get in there and treat. We want to be a technician. We are manual therapists. We want to get in there, feel the tissue, and see what it tells us. I get a lot of people that are like, I'm an intuitive healer. I just kind of go with the flow and see what the tissue tells me. That's a bunch of nonsense. You have to learn to think critically. And my goal with a lot of these trainings and these videos is to get you on the idea of becoming a clinician first and then a technician second. So one thing we teach in our system is taking a thorough and detailed history. And there's actually 12 history points that really you need to know before ever doing an evaluation, putting your hands on someone, because I always say, if you don't know what it is, the problem is in the first place, you sure as heck can't fix it. So a couple of really important things in a clinical sign for hip impingement that I'm looking for. One is going to be age. A lot of times there's 2 types of problems in there. When someone is a little bit older and they're getting that hip impingement presentation, I'm definitely thinking there's some damage to the bone, some osteoarthritis and things like that. But it also can be very common in a younger population, like teenagers and even people in their 20s and early 30s. So there's 2 criteria when I'm looking at the age factor in the clinical signs. Next is just going to be symptom location, where they feel it. A lot of times people will feel pain in that front part of the groin there, right above the rectus femoris in the hip, but they also will feel it sometimes on the outside as well. So where they feel it is very important as well. Then the quality, a lot of times it's going to be sharp. It might be stabbing. It might be popping. It might be clicking. It might be grinding. A lot of those quality types of presentations will give us some ideas of like what we're dealing with and what specific structures are involved. Next is symptom intensity. So whenever I'm doing this, I always grade it on a scale of 0 to 10. 0, no pain. 10, you wouldn't care if we just cut the area off. And I want to know a couple of data points here. First is I want to know, when's the last time you had an episode that was so bad? And what has it been on average over the last 30 days or so? And a lot of times when someone has some hip impingement presentation, especially damage to the cartilage, to the joint and the tendon in there, they can get that 7 or 8 or 9 out of 10 with certain movements or certain activities. Next one is just going to be what makes it worse. I always call this the provocative. We should always have something that makes a problem worse. So they might say, hey, if I've been sitting for a long time and I stand up, or I try to run, it hurts, or I do a deep squat, something. We want to see some type of provocative thing in there as well. Next thing we want to know is there anything that makes it better? And a lot of times just rest, maybe putting the leg out in a different position, unloading that externally, internally, rotating it, taking the pressure off of there. We want to see that as well to help us understand what's going on and where we need to go. Next one is just going to be accidents or trauma. Is there a history of accidents or trauma? Have they had any injuries, playing sports, weightlifting, falling, things like that? We want to know this as well. And then last one is going to be their recreation and their activities. What did they do? And a lot of times I'll see this, especially in the recreation, I see this more in the younger population, where they just overuse that area. And a lot of times they're playing one sport year round and their hip just can't really adjust. And as they're growing, it puts more wear and tear on that. So I tend to see this in athletes that, in their younger years, anywhere from like 12 to 18, specialized in some type of sport or some type of activity that can lead to the hip impingement presentation. And then also maybe just what they do for their job. Are they like a blue collar worker? Have they been hard on their body? Are they maybe overweight and they've been carrying around that extra stuff? These are all data points that I want to see to really understand what's going on. And then your job is to collect that data, then start to put it all together and break it down into what it could possibly be. And there's only 7 possible problems that can show up in any musculoskeletal presentation. It can be a bone problem, a cartilage problem, a disc problem, a ligament problem, a nerve problem, a soft tissue problem, or a tendon problem. So what I'm going to break down in the rest of this presentation is the 4 common problems that I see with a hip impingement presentation that a lot of times a lot of providers completely miss. So before I get into that, why it isn't a hip flexor problem. A lot of times when people come in and they're like, hey, I get some pinching in the front part of my hip, when I'm squatting or I'm doing some yoga pose, and everyone's like, oh, it must just be a hip flexor strain or a hip flexor problem. The thing here, though, is the symptom location is only one part of the entire history. So a lot of providers, they just get in there and they're like, oh, it hurts there. Let's get in there and do it and check it out. But you want to know a lot of that other data, like what does it feel like? Have they had trauma? Is it more of a biomechanical distortion or things like that? We want to collect a lot of data. We have to put all the history points together. Another thing we want to consider is, was there an accident or trauma in there? And a lot of times if there was a direct trauma to that area, then maybe I'm thinking it's a hip flexor problem, but more than likely it's not. And then the activity and recreation is very important to consider, as I talked about in the earlier slide. Like, what do they do? Are they specializing in the sport? Are they playing soccer year round? Are they playing baseball year round? Are they playing basketball year round? That repetitive overuse stuff can really put a lot of damage on the joint and the ligament and the cartilage in there as well. And then lastly, just understanding the idea of cause and effect. So a lot of times when it's hurting in that anterior part of the hip, a lot of times that's just a compensation for something else biomechanically not going on. And the pain that they're feeling in there could be a referral pain from somewhere else. So a lot of people go right after the pain. The symptoms are important. They let us know it's a problem, but they don't tell us everything. We want to know the history as well. That's what I'm talking about, slowing down, collecting data, and getting a better idea of what's going on. So one of the most common presentations for when they get pain in that front part of the hip or off in the side is considered impingement. But there's different types of impingement that can actually happen there. One is just hip OA, which is osteoarthritis. That's where that age factor starts to come in. Basically, over time, the joint just gets really beat up and it gets damaged. The hip just gets older before its time. So I'm going to see this a lot in a presentation, specifically with an older person. So that's going to help me in my history as well. The other one are these things called cam and pincer lesions. So this middle one here is what's called a cam lesion. That's where it's actually up on the in the pelvis, where you get this extra bone growth in through here and in through here as well. And then the other one is called a pincer lesion, where you get the bone growth up through here as well. So why do these happen? A lot of times they can be a combination. So they tend to happen a lot more in a younger population. So basically, as people are growing, their growth plates aren't fully developed. And when they're not fully developed, and you put more wear and tear on there, there's a rule in the body called Wolff's Law. The more force you put on the bone, the more it will lay down. So the body actually starts to lay down more bone in these areas to help buffer that area and buffer that load. But over time, now the hip can't move how it's supposed to. So when it goes to articulate and go back and forth, it actually jams into there and jams into the bone. And then eventually, what can happen is it can put pressure on the labrum there and cause damage to the labrum and cause a lot of issues as well. So this is where age component is really important, and also activity is very important too. If I have a younger person, I'm like, what did you do? What did you play? What was your activity load like? And also with an older person, like, were you a blue collar worker beating the hell out of yourself for years? Did you not move? Did you carry around a bunch of extra weight? That's where all those data points come in. So then what happens, like I said, when those cam lesions form, you get what's called a labrum tear. So the job of the labrum, it's basically just a cushion between the femur and the pelvis. And it just wants to sit in there nice and easy. It's kind of moon-shaped when you look at it, and it just serves as a cushion. It's basically cartilage in there. But when that cam lesion's in there, what happens is they have to force the hip open harder than it should. So it's kind of jamming it in there. So each time you get some fraying of that labrum, and then it will present with like some popping, some clicking. The hip will kind of feel loose and unstable. The problem for a labrum is it doesn't get good blood flow. It doesn't get good oxygen. So it doesn't heal up as quickly as it should. And a lot of times people end up having that surgery in there where they go and fix the labrum, but the labrum is the effect. It's not the actual cause. And a lot of times that cam and pincer lesion's in there. So it's going to continue to cause that problem down the road as well. This tends to be a younger person problem as well. I see it anywhere from like 12 all the way up to like 30, maybe like mid 30s. As we start getting higher up in the 40s and 50s, I'm thinking more of just that hip degeneration in that osteoarthritis, but the labrum tear is going to be way more positive in a younger population. So next one, getting into soft tissue. A major component when you're getting pain in the front part of the hip is a dysfunction of the adductor magnus muscle. It is a huge muscle. If you look at it in the cross section here, it basically takes up the entire mid part of the thigh. It's very important in flexion of the hip. You need it in running, jumping, squatting, moving. It's very, very important. And over time, when people overuse or overwork their areas, the muscle starts to develop this stuff called adhesion. It's like glue, also known as scar tissue, and it makes the muscle weaker, makes it less flexible. So a lot of times when someone had a problem with a labrum or maybe a 𝘭 or pincer lesion, it actually started with the adhesion in the adductor magnus first. So then the muscle can't generate the force how it needs to, so it puts more wear and tear on the joint and the cartilage, lays down more bone. But that's definitely an area where you can go in and address and treat it manually by getting proper depth and tension on the adductor. It is such an important muscle and it gets missed so many times in an anterior hip pain presentation, and addressing it is going to be key. And then the last one is going to be what's called the posterior hip capsule. So on the back part of the hip, there's this ball of yarn. It looks like a ball of yarn. It's basically a ligament. It's called the capsule, and it basically allows the hip to have some support and stability. And over time, like I said, when there's more force on the hip, maybe more repetitive use, trauma to the area, a lot of high activity, it stretches out this capsule. When the capsule gets stretched, doesn't get enough blood flow, doesn't get enough oxygen, starts laying down all that adhesion, makes that area weaker, less flexible, which in turn puts more pressure on the hip. So breaking it all down, there's some components of bone, there's some components of cartilage that are very important in the hip impingement presentation. And if it's early in the process, you're probably more likely going to have issues with the posterior hip capsule and with the adductor magnus as well. And even if it is a chronic injury where maybe that labrum's been wrecked for a long time, maybe they have a 𝘭 or pincer lesion, maybe they have the hip OA in there as well. There's still work you can do as a soft tissue provider by treating the capsule and treating the adductor magnus. Because I always say, think of those other things, the 𝘭, the pincer, the labrum, the osteoarthritis, as someone's thumb and they're stuck inside a car door. The car door is all that adhesion around there in the capsule, in the adductor magnus. So you getting in there and treating that's going to take the pressure off and give this a chance to heal up. But in the current medical model, we usually go after the bad stuff first. We're like, oh, your labrum's torn, let's repair it, instead of being like, why is your labrum torn? Was there an actual trauma there, or is it a biomechanical dysfunction that's continuing to build up over time? You want to ask questions, get to the root of what's going on, have a plan, then get in there and fix it. Know exactly what's wrong so you're not guessing, you're not stuck winging it like a lot of other providers do, doing a ton of treatment but not really having a plan. So that's all I got for you guys in the video. I appreciate you watching. You can share any insights you might have gotten in the comment sections below. Also, share this with other providers that you think it might help. And lastly, go download our free training modules. The links to that are wherever you're consuming this. We're really getting to this idea of teaching you how to do treatment better, faster, more efficiently, which makes more money for you, takes the wear and tear off your body, and helps you help more people get out of pain for good. I appreciate you watching, and we'll catch you on the next one. Bye.